Hello, everyone. As most of you know, my name is Lindsay Putker. I am an inpatient charge nurse here and the EPIC project champion. And for our presentation today, I'm going to be talking about what is known as CDiff. So that is something that we look at here at our hospital. It can be a hospital-acquired infection, and it is something that we're currently struggling with here at our facility. So I wanted to do a project on it and do some education. So for some of the objectives, so by the end of this presentation, I hope that you will be able to complete a CDiff risk assessment in EPIC. So currently we are in Meditech, but we are going live, as everyone knows, in EPIC on June 8th. So I'm hoping that you'll be able to complete that risk assessment by the end of this presentation in that system. And then also by the end of this presentation, I hope that you can name 2 risk factors on the CDiff S-bar that we utilize here at St. Joseph's Highland. And then also I hope that you can identify one negative implication of CDiff, or one negative outcome that comes from CDiff. So what is it? It is known as a bacterium that causes diarrhea and colitis, or an inflammation of the colon. So it is a bacteria that causes diarrhea, dehydration, all of these bad signs and symptoms that can actually be deadly for the patient. So how do we get it? So there are CDiff bacteria in the environment, in the soil, and it can actually be spread very quickly. It's very contagious, and it can live on things for a very long time. So if you're using something that doesn't clean the spore, then you can actually keep spreading it. So our CDiff numbers, so like I said, this is something that we're struggling with. So as we know, we have a shared leadership model here with Breeze, Highland, and Greenville. And Breeze and Greenville are doing very well with the process for CDiff right now, but Highland is a little bit behind. So our goal is 0, which the other facilities are able to do. But since this fiscal year started in July, we already have 3. So we're much below our mark of what we usually are and what our goal is. So this is something that we really want to focus on for our patients and for their safety and for the quality implications. All right, so what are the risk factors? So any patient that's above the age of 65, which here is a critical access hospital with swing beds, we do see a lot of elderly people that are above the age of 65. So we are already in a high-risk area in our inpatient department at our hospital. Anyone on antibiotic therapy. So antibiotic therapy is one of the biggest risk factors on CDiff, because antibiotics actually take away the good bacteria that is in your digestive tract, and so that those CDiff spores then can actually start to live. So we actually have antibiotic stewardship here at St. Joseph's Highland, where our pharmacy and our infection control and quality team look at our antibiotic therapy and see if it was appropriate when we were doing it, if we stopped them early enough, and factors such as that. So as nurses, though, I'm wanting you to be able to look at that and say, my patient's on antibiotics, why? I want you to start asking the doctors, when can we de-escalate them, so that we are able to decrease that risk for our patients of being on those antibiotics. We can be advocates for those patients with that. Any patient with a history of CDiff is automatically at risk, because CDiff patients are much more likely to get it again than other infections. Anyone on immunosuppressants, so anyone with a decreased immune system, is more likely to get that bacteria. Any patient on proton pump inhibitors, any patients with other gastrointestinal diseases. So if they've had colitis in the past, or if they have Crohn's disease or anything like that, they're more likely to get C. diff. Patients who are hospitalized for long periods of time, So, like I said, here at Highland we do have swing beds who can stay up to 6 weeks. So if we are not doing the appropriate infection control preventions and not cleaning with that certain solution and using bleach wipes on everything that we're taking in and out of the room, then we are likely to keep spreading that. So anyone who's here for a long period of time is also at risk. And then anyone who's been hospitalized recently. So facts of C. diff and some of the implications of why it's important. So it is the leading cause of hospital-acquired infections in the U.S. So of even catheter-acquired UTIs, our central line infections, C. diff is the highest implication in the United States for hospital-acquired infections. And then hospitals are, on average, in acute care facilities, which we are, they would spend $4.8 billion a year on this. So with every C. diff, hospital-acquired C. diff that we have here, it has huge financial implications on our facility as well. And then it is estimated that C. diff has been the cause of 29,000 mortalities in a year. So across the U.S., 29,000 people have died because of this disease and this infectious process. And then about 500 people have suffered from the infection. So 500,000, that one astonished me. So 500,000 of our patients are suffering with this every year. And then there's the increased length of stay. So for our critical access hospital in particular, we have to stay on average below 4 nights of a patient being here in an acute stay. So that is it's a huge thing for us to get these patients back home as soon as they can for them and for our hospital. So if they were to acquire C. diff, that involves treatment and them staying here for monitoring, and that increases their length of stay. So what can we do? So performing appropriate hand hygiene. So we all get those hand hygiene papers that we pass out and have to fill out. And there's monitoring and things like that. But for C. diff especially, you can't just use the hand sanitizer. So always washing your hands with soap and water and making sure that you're doing that entering and leaving the room. Performing contact precautions. So making sure you have that gown and glove and actually having the gown on appropriately, which can be difficult, but having those contact precautions on and using them appropriately, not having the contact precautions out in the hallway after you've been in a C. diff room to grab something or anything like that. So making sure our contact precautions are being used appropriately and that they're being started as soon as possible. So if we are screening someone for C. diff, that we're starting that contact precaution right away when we're starting the screening process instead of waiting till it comes back positive. Being aware of the signs and symptoms. So if they are going to have C. diff, they will have a fever, they'll have a white count, they'll be showing signs of infection, they'll be having many stools a day. I know here we say if it's 3 or more in one day, then that's when we need to start thinking about it. So if they're having frequent diarrhea, if they're having vomiting even, if they're just having these infectious signs and symptoms and we can't pinpoint it, then we may want to think about C. diff too. They have procedures on how to decrease unnecessary testing. So we'll get into it later about colonization of C. diff, but making sure that we're not testing people who don't need it. So they can have diarrhea, but if they don't have any infectious symptoms, then they don't have C. diff because they don't have an infection and they're not showing those signs and symptoms. So we need to make sure that we're not unnecessarily testing, because if they do have those spores and they're colonized, then we'll be treating them and they won't even have it. So we'll be treating them unnecessarily, which is bad for the patient as well. And then wiping down equipment with the bleach wipes when we're taking anything out of the room. So if we're changing out an IV pole, our wows, how we have computers on wheels here, wiping all of that down whenever we're leaving the room after we've been in there. Our scanners, our pens even. So anything that we bring in there that we're bringing back out needs to be bleach wiped. So colonization, like I was saying, so why we assess before we test. So colonization is common. So when they have colonization, that means that whenever you test for C. diff, it could come back positive, or they are having diarrhea, but they have none of those infectious signs and symptoms. So that means they don't have a fever, they don't have a white count. Then they would not be appropriate to test because you shouldn't treat the colonization because it's not an active infection at that point. So they will test positive for C. diff if you were to test someone that is colonized, but then the patient again will be treated unnecessarily. So getting into the documentation and our process here of C. diff. So we have looked at C. diff differently to where we do the risk assessments in our documentation, but that we're also looking at the SBAR that we created, which I'll show you also before we just test. So here's our current process in Meditech. So as most of you have seen it, it asks about some of those risk factors. So is the patient 65 years or older? Are they from a nursing home where they're in a hospital infection or a hospital type environment for long periods of time? Have they been on antibiotics? Are they on a proton pump inhibitor? And do they have a history? So all of those risk factors that we talked about earlier, they're all in this, this tool right here. So then it'll actually score it and it'll tell you what to do. Although we know and we want to educate our nurses that we don't just follow the algorithm that our EHR automatically gives us. So we know we want to assess before we test. So we want to make sure that we are assessing everything before we send anything unnecessarily. So Epic has a new risk factor tool. So whenever you get a patient and they're admitted, there will automatically be required documentation for you to do a C. diff risk assessment each shift for 3 days. So we know if it's before the 3 days that they're tested and they're positive, then that means they got it in the community and it's not hospital acquired. So in Epic, it will show that there's required documentation on that for the first 3 days. So here in the Epic tool, it'll ask you, is there 3 or more loose stools? So if you say yes, then it'll keep you going. If you say no, it'll stop the intervention. So then it'll ask, have you had a positive C. diff test in the last 12 months, since that's a risk factor. Then it'll go to antibiotics within the last 90 days, admitted from any other facility or any hospital encounter within 90 days. So it'll ask you all of these, and then again it'll score it like it does in Meditech, so it's not much different, it's just asking you different questions.
For the first one, if they say no, do you have to answer the rest?
No, it'll automatically stop it.
Okay.
Yep. And then if it tells you here that if you have a score of 2 or greater, you need to place an order and start contact isolation and test. So that would only be 2 of these up here. So, you could say antibiotics within the last 90 days, yes, and they've been in a hospital in the last 90 days, yes. So it'll automatically tell us that we need to start everything for C. diff. But as we know, that's not our process here because we found in the past that we were testing way too much. So in EPIC, we are currently looking at this, and the infection prevention team and the EPIC Project Champions are currently working on this, but it would have to be a system-wide initiative for all of HSHS. So for this to be changed, where it wouldn't give us that 2 or greater to automatically test, we have to get the whole system to approve. So it's going to be a work in progress. So that's why we want to make sure that you guys are educated, that we don't just start a CDiff, that we just don't start isolation right away and test right away and all of that. So say we do though get a 2 or greater, then we'll go to our CDiff SBAR. So for those of you who haven't seen this before, we have a situation. So if the diarrhea screen is yes, so basically that situation is saying you were in EPIC and it told you that your patient is at a high risk for C. diff and that you should test. So then we're going to go to our background, and it's going to show our risk factors. So have they had a history of C. diff? Have they been in the nursing home recently? Are they receiving PPIs? Are they receiving antibiotics? And are they 65 or older? So there's our risk factors. So if they do, say they're 65 or older, like we said most of our patients are, then we would check that. But then we'd go to assessment, and we said patient began having diarrhea on. And then you say, they haven't been having diarrhea though. They haven't had diarrhea since they've been here. So then you automatically know that that diarrhea assessment, it doesn't count. It doesn't meet the criteria. Have they been having the signs of infection? So have they had a positive SEERS for sepsis? Do they have a fever? Are they having abdominal pain, nausea, vomiting? No? Okay, then that won't work. Have they been having laxatives? So say they have been having diarrhea and you put yes, they've had laxatives. They take them daily even. So then you would mark that, and that's a non-infectious source. So that automatically you know that if they are having diarrhea but they're taking laxatives or they're taking a colon prep or anything like that, that you won't test because it's non-infectious. So if there's anything in here that does not check any of those boxes, then you will know not to test. And then you'll have a recommendation. So say it met all of them. It met the risk factor. They're having diarrhea and they're having infectious signs and symptoms. They've had no laxatives, no bowel preps recently, nothing like that. Then we could put that it's recommended. But then you also want to talk with the provider. So we always want to talk with the provider before we order anything. So we can use this tool though to talk to the providers. We can say, hey, we did the C. diff risk assessment. It said she was at risk. So we filled this out and it does look like it met all of the boxes. Do you want to go ahead? It could also go the other way where you ordered a C. diff. The provider ordered a C. diff and you go to fill out the SBAR because you want to make sure that we're not unnecessarily testing, and you can use this as a tool to them as well. So yeah, she has a risk factor, but she has no signs and symptoms of an infection. She's only had 2 loose stools, and it doesn't have mucoid in it, nothing like that. But again, there's no signs of infection. And we can actually use this assessment tool then to show them of how it's not appropriate. So say though the doctor's like, nope, I still want to test it. It doesn't matter, they're having diarrhea, I just want to get it done. Well, then there's also a checklist to talk to our infection preventionist, Allison. So before we test any C. diff, we need to talk with her first, because sometimes if we feel that it's unnecessary, she's able to be that go-to person to talk with the provider and say, this is why it's not necessary. This is why we shouldn't test it, or if they don't want to test it and we feel it's appropriate, then this is why we should test it. So she's always a resource person, And we want that resource person to be called before we make any decisions on it, since she is the expert. So these are all tools that can help us, but she's also a resource too. And then our charge nurse also needs to sign, and the nurse needs to sign. So we're really making sure everybody's accountable and everybody's using this teamwork so that we can make sure that when we're sending something, it's appropriate. Any questions about the SBAR? Okay. And then there's also an algorithm on the back of the SBAR. So say you are filling out that tool and you're like, I don't know if I should mark that, I don't know. There is this algorithm. So it starts with, start the SBAR if the diarrhea screening is yes. So CDiff risk assessment was yes. So we're automatically going to go to the next one. So is this a chronic pattern for the patient? Do they have Crohn's? Do they take laxatives daily? Is this something that's just normal for them? So if that is yes, then you would automatically not start the test then. So it'll show you with this algorithm what all that you should do for different scenarios. Okay, so process overview is we complete a CDiff risk assessment in EPIC, which will be a required documentation either way. So we will complete that. And then if the score is 2 or greater, or if it's brought to a nurse's attention, hey, the CNA comes up, hey, this patient's been they've had 4 loose stools today, then we should start this process. Or if the CDiff risk assessment shows us that we need to start the process. Then we will review the CDiff SBAR. We'll review the CDiff algorithm if there's any questions or if we're stuck or we don't know what to do. Then you can also look at that algorithm and then speak with your physician about CDiff testing. And then if you do feel that the testing is appropriate, please make sure that you call Allison, our infection preventionist, to confirm that it is appropriate and that we're not missing anything. Just that final check. So there are more opportunities with EPIC than what we have now. So the infection preventionists have also met with our quality reporting team, and we were able to get more reports on CDiff. So every day Allison will be able to go in and see every patient's risk factor. So if there's a risk factor of a 4, she can look at that and she can say, did they test, did they not test? If there is an order for CDiff, that will also tell them in that report, and then it'll also say if we collected it or if we did not collect it. So she'll be able to see a doctor ordered CDiff, but we still need to go through the process because it's not collected yet. So those type of reports will be in there now for them, which they currently do not have. So that'll be something that they will have much more data on. We also have improved reports on antibiotic stewardship. So they will be able to get many more reports on what patients are on antibiotics, how long they've been on them, and if we can de-escalate them. So there'll be much easier reports for our pharmacy staff to be able to look at, for them to be able to see if we can de-escalate. And then the required screening. So EPIC will make you do the CDiff risk assessments for at least the first 3 days. So there will be that required screening as well. And then conclusion. So screenings will be changing in EPIC. So like you saw from Meditech to EPIC, it's the same kind of thing, but the questions that they ask will be different. So we'll have to pay attention to those and make sure of how we're answering them. And then the CDiff process will decrease over testing. So this whole process is to make sure that we're testing the appropriate patients so that we're not getting those false positives. And then CDiff does have major implications for hospitals and patients. So patients will have to stay in the hospital longer, which none of them want. It's costly to our hospitals, and it'll increase our length of stay specifically for here. And then nurses can be advocates for the patients. So we now know the risk factors. We know the signs and symptoms to look for. We know that we can advocate on those antibiotics and making sure that we're de-escalating as soon as possible, having those discussions with the providers, and having the discussions on the SBAR, and whenever they do want to test, us being an advocate and saying this is not appropriate to test because we don't want to treat something that does not need to be treated. Any questions? Thanks, guys.